In conversation with Dr. Sipho Kabane, Registrar and Chief Executive of the Council for Medical Schemes. Previously, we had highlighted in the previous episode, we've spoken about the regulatory philosophy of the Council for Medical Schemes. In this podcast series, today we're going to be focusing on key policy issues. Within the last 5 years, during his tenure, he had faced multiple policy issues and the consternation of some other stakeholders to these key policy issues. Now, Doc, let's talk about key policy issues the last 5 years during the tenure. I think it's very important. And this is where some of the stakeholders we've spoken about in the previous session, that they might have certain issues with the office of for the Registrar. But for the purposes of our viewers, may you just, in broad sense, highlight those key policy issues that the CMS had to deal with in the last 5 years, and how did we deal with them, and what were the outcomes?
No, thanks, Stephen, for that. Stephen, let me start by just going back to Section 7 of the Medical Schemes Act, where our mandate as CMS is captured. And you'll see that there's a provision that says that the Council will regulate this industry in a manner that's complementary to national health policy. There's also a provision that says we need to be advising the Minister of Health on all matters that are related to the medical schemes industry. There's also a provision that says we need to be providing Minister with information that we've gathered through our regulatory work. So in a sense, when you look at these three provisions, they already invite CMS to be a key participant in the national policy landscape. So I just wanted to put that clear, because often people think we should just be regulating schemes and not bother about what's happening in the policy discussions. Now, the other important thing is, whilst we regulate what is often referred to as the private sector in the country, through medical schemes, administrators, managed care organizations and brokers, one cannot, when you look at policy issues, forget that there's one national health system, irrespective of the sectors. And when people look at whether we are performing well as a health system, the data and measurements that they report on are reflective of both the public and the private sectors. So it's important to look at that. Now, having said that, one of the fundamental challenges faced by this country is the fact that in terms of the private sector, the engagement, you've got commercial vested interest that you need to balance against the public health interest. And our understanding is that as we regulate, we need to make sure that these factors are balanced and that scheme members remain protected as we make those balance. So you'll see that our approach to policy issues is also to ask, how does this impact on scheme members? How does this impact on extended family of schemes and the public out there? Because when you talk of scheme members, you need to be thinking of the current as well as potential scheme members. So I know this makes some stakeholders, to have some discomforts, but that's how.
That's the reality.
Yeah, that's the reality of the situation. Now, just coming back to your original question, in terms of just saying a few things around some of the issues that have emerged in the policy landscape, one can't start, this discussion without talking about the national health insurance and the fact that the president has finally signed it off from a bill into an act, and that there's an understanding that the different sections of that act will be promulgated in a phased-in approach. And this phased-in approach respects the fact that you need resources for implementation, you need capacity, you also need consensus and engagement between all the parties that would be affected. So in our own space here, we know there's a great concern around Section 33 of what sits in the Act here, that basically says that medical schemes will only be allowed to provide for services that are not covered by the NHI fund. In other words, it will be a complementary service. And this is supposed to happen when the NHI is fully implemented. Now, a lot of people jump the gun, even without understanding what the picture of full implementation looks like, what benefits would be covered, to make a determination that that is full implementation, and the different transitional arrangements that will need to be put in place leading to that.
So are you, when you say people are jumping the gun, they're already painting scenarios, or is this, when they jump in the gun, is there research being done about what they are purporting that NHI will look like?
Well, I'm not sure what people are doing in terms of the research and the detailed work that needs to be done for one to fully understand. But I think it's very clear from the articulations of the minister and other key stakeholders that are charged with implementing the NHI that a detailed implementation plan that clearly articulates key, milestones will need to be put onto the table, and people will be given an opportunity to engage with it so that everyone understands how it will unfold. I think only then can you come with criticism that says we do not like this, we like that, we want this to be changed. But when there's hardly an implementation plan that is in draft form that has been put on the table, I think these disagreements are based really on lack of evidence and ignorance. So our own view here in terms of this Section 33 of the Act and what's set in the bill is that CMS is not going to fight to ensure that it continues to exist when its mandate has been exhausted. We believe that the path towards full implementation will clearly articulate the changes that need to happen at the CMS in terms of the size of the organization, its mandate, and how it will do its work. And we think those changes will also be aligned with the transitional arrangements that will be mapped out in terms of the role, size, and function of the schemes, administrators, managed care organizations. And all of that is up for discussion. That's why, for me, I think we should rather be, directing our energies at trying to map out these key transitional milestones and what the final, picture would look like of full implementation. So for us, as an organization, we are playing a continuous supportive role towards the rollout and implementation of the NHI. And yes, we want to allow National Department of Health and the newly established NHI wing to actually drive the process. Yes, and we think our job in this transition is to make sure that we regulate, this industry in a manner that still ensures that there's stability in the sector, members are protected, schemes don't find themselves in trouble. So we will be playing a facilitative, supportive, guiding, and a role that will make sure that with more communication, people will understand how things are going to unfold.
Is it like when we played that facilitating and connecting role on the low cost benefit option?
We'll come to the low cost benefit option because it's one of the policy areas that are in the landscape. Maybe let me jump to that here. And before we even look at the merits and demerits of the low cost benefit option engagements, one needs to start by making sure that people understand what it is that we're talking about. And I've always found it useful to think of the low cost benefit option discussions as talking to two key issues. Firstly, there's a desire by schemes to provide an option for low income earners. And this is based on the thinking that there are low income earners that are not covered currently, through the current medical schemes dispensation, and that we could devise a product that would, make sure that they are covered and that they benefit from the schemes. On the other hand, we've got private insurance products that have been exempted through the demarcation framework that are existing in the land space. So the big question is, should the minister, who has the mandate to execute this, by the way, should he say yes to schemes providing a low cost benefit option? And should he say yes or no to the continued existence of these private primary health insurance products? So that's the big decision. And yes, as CMS, we've played a very big role in ensuring that we engage with key stakeholders in the medical schemes industry and outside, just so that when the minister looks at whether they should be making this decision in one direction or another, they've got all the facts in front of them. So we've undertaken an extensive consultative process, and we've talked to schemes, we've talked to administrators, we've talked to managed care organizations, we've talked to consumers and consumer right groups, we've talked to service providers, and we've talked to insurance service providers.
We left no one.
And through an intense and extensive consultative process, people were able to make oral as well as written submissions, and we've even had to extend dates to allow for everyone that wanted to make an input into the process to do so. And after a while, we were able to get all the information that we needed, which we've consolidated into a report with clear findings and recommendations for the minister to, consider. And this was presented to the Minister of Health in November 2023, and yes, we're still awaiting for him to articulate his position, having considered the findings and recommendations of that report. And yes, we remain there as a supportive structure where we can assist the minister in terms of gathering the relevant information and advising on any of the implementation issues. So this is a matter that we, from our side, have brought into conclusion. And I wouldn't want to start talking about the outcomes of that process. And I think let's respect it. Let's allow the minister to consider the report. And at the right time, when he's ready to articulate himself in terms of the final decision, then we can engage with key stakeholders on those matters. So we believe this is one of the biggest achievements, because it's a matter that has been outstanding and needed to be finalized by 2019. But we've gone through the COVID and other delays, and with the support and collaboration of key stakeholders in the industry, at least we've reached that key milestone.
Another important policy, I think, whether you could call it a policy, and maybe you could expand on it, that is very detailed in its nature and it's the way it's crafted, is the PNB, the prescribed minimum benefits. There's assertions that every 2 years we need to review. Others have said that we're not reviewing, but there's a lot of work that has been happening under the prescribed minimum benefits. Maybe you could just, on a high level, just give us the type of work that has been done, the reviews that have been done by the CMS.
Yeah, Stephen, maybe let's take a few steps back and just try and get a good understanding of what we're talking about when we talk about prescribed minimum benefits. Because sometimes when we don't review that, you find yourself now having a view that is not well informed. So there are these set of benefits that are mandatory, that each scheme must pay in full, irrespective of the option that you belong to, because these are guaranteed by law through the Medical Schemes Act. And this makes reference to a set of diagnostic and treatment pairs, which are around 270 in number. And in addition to that, you've got a list of chronic diseases that are around 27, which, you know, if anyone suffers from them, a scheme needs to pay. In addition to those, you also have all the emergencies that can happen to a scheme member, which need to be paid in full until a determination has been made whether they are a PMB or not. Now, once you've understood what the PMBs are, and you'd say, what would a review consist of? In my mind, I think there are these activities that CNS has been busy with and has actually, you know, escalated and accelerated over the past 3-4 years. And this work involves the determination and development of a code of conduct around PMBs. Now, the value of that code of conduct is that it guides people in terms of how to make funding decisions around PMBs. And in order for you to come up with a code of conduct, you must actually do some kind of a review process in terms of looking what benefits exist and how they should be, you know, managed. So for me, that constitutes a review. Since 2016, CMS has been producing 10 scripts
Each year.
that clearly articulates how certain conditions that are PMB related need to be managed by members of schemes, by service providers, by ensuring that there's a clear interpretation and understanding of what those conditions are. Thirdly, there have been sessions. Each year we've produced 10 what we call definition outputs. And in definition outputs, we go back and say, if you've got a PMB, what entitlements are members, you know, supposed to get here? And we go and say, okay, how do you diagnose? How do you treat? How do you provide rehabilitative services? And what medicines are allowed, what medicines are not allowed? What kind of technology do you need to diagnose? And all of this is based on making sure that you update these benefits in line with the technology developments and the developments in medicine, and making sure that the latest evidence-based information is incorporated in the understanding of these entitlements. Now, in our view, all of this work, which can be quantified and is extensive and significant, constitutes PMB review. When there was COVID-19 pandemic, this organization led the industry in ensuring that COVID-19 is declared a PMB, and when the vaccine became available, we again consulted and coordinated the industry and ensured that this is included. In our view, that constitutes part of the review.
So,
but let me just add that obviously the current set of PMBs have got certain systemic issues. These issues cannot be reviewed and completed even within the time limits that are set in the Act itself that talk about the 2-year review. What actually needs to happen is that an extensive consultative process needs to be undertaken. And this is what I call the extensive and comprehensive review that needs to determine what sits in that bag of benefits or not. And in our view, we don't think it's something that can be done within the 2-year process because of its consultative nature. And yes, we've started with that in 2016, and we are at the tail end. And the key aims that we wanted to introduce was to introduce a primary healthcare element to it. and to make sure that we change the service offerings from a list of diseases into service packages. We're hoping that this primary healthcare element is going to be phased in so that it doesn't create affordability issues for members of schemes or the schemes themselves. So we're at an advanced stage. We've done affordability studies, we've done the ability to pay studies, and we've looked at costing this package, and we believe that through a smart way of implementing it in a phased-in approach, it can be financed through the current arrangements, and schemes can be able to absorb this here.
Yeah. So, finally, Registrar, looking forward, we have these issues of TWIPIX, FSR, Coffee Bill, we have Section 59, we have the Medical Schemes Amendment Bill. Maybe just sum it up for us, from your side, strategic view. What impact or effect will these have on the environment and also on the CMS, to your knowledge?
Right. So let me start by saying that the Medical Schemes Amendment Bill, as well as the Financial Services Regulatory Act, and the challenges that emanate from those two pieces of legislation, they basically touch on the basic tenets of the work that CMS does in terms of trying to redefine its mandate. And our concern is we need to preserve the mandate of the CMS, which is contained in the Medical Schemes Act, but we also need to support the establishment of Twin Peaks, as long as it doesn't create an overlap between these legislation. And it also touches on a key strategic outcome that I've talked about earlier on, of being an effective and efficient regulator. If there's confusion about who should regulate medical schemes, then we can't be effective and we can't be efficient. So we want to make sure that the mandate is retained, it's clear in terms of where our regulatory mandate starts and where it ends, and where the FSRA starts and ends. And we believe that with the current engagements that we're having with the FSCA, Prudential Authority and Treasury, we'll be able to harmonize those pieces of legislation. And we think that will assist in mapping out a way forward. The other area that I just want to talk to, it's the health market inquiry. Health market inquiry actually exposed the regulatory gaps that sits in our industry, which are sitting mostly in the supply side
of things.
Yes, and basically there was a point made that all of these gaps were created and continue to operate even with the oversight powers that CMS has. As CMS, we've taken that report positively, and we've looked at all those areas that have been identified for CMS to address. And yes, over the past 3-4 years, we've been implementing some of the findings and recommendations, and we've had extensive engagements with the National Department of Health, because we believe some of these need a multidisciplinary approach that would include National Department of Health, the Health Professions Council of South Africa, the Office of Health Standards Compliance. But we believe overall, a lot of the findings and recommendations are implementable. Yes, some of them may have systemic challenges. For instance, the establishment of a new supply side regulator. The country and its resource base may not be friendly to that kind of a recommendation, but we've made significant progress. And yes, at the time when we're required to provide details on this, we will be able to do so.